Good afternoon. How's everybody doing?
Doing well.
Good, good. Well,
Good. Hello, hello.
welcome, Dr. Bedrosian. Thank you for doing this presentation on glucose management in hospitalized patients. Very, very appreciative that you're taking the time out to do this for all of us. Just want to let you guys know that there is available one CE unit for the BRN. So if you guys want any CEs, please make sure that you message education department so I can get you the post test and the evaluation form to complete that so we can get you your CE. Anyhow, I'm going to go ahead and pass this over to Dr. Bedrosian, and thank you guys for attending.
Sounds good. Okay. So, hi everyone. My name is Dr. Nora Bedrosian. For those of you who I haven't met yet, I'm an endocrinologist, and I'm currently seeing inpatient consults at Mission, as well as seeing patients outpatient just next door. I've been asked to give this talk about glucose management in hospitalized patients. This was initially intended as education for nursing staff, but please feel free to stay, even if you're not a nurse. I tried to create a presentation that would be helpful in some way to every part of the medical team. You can ask questions as they come up, or I can take questions at the end of the talk as well. Thank you for joining, and hopefully you get something good out of this. Trying to click my next slide. Okay. So objectives of this talk, first, to explain how acute stressors affect blood glucose in the human body, to define the significance of maintaining optimal glucose levels in hospitalized patients. I'll explain key principles of insulin therapy in hospitalized patients, identify patient populations that are at higher risk for glucose dysregulation during their hospital stay, and come up with individualized glucose management plans based on patient-specific factors. Going through a little bit of the established protocols to prevent errors related to glucose monitoring and insulin administration, and then outlining strategies to manage hyperglycemia and prevent and treat hypoglycemia. So first, I just want to go over how illness and hyperglycemia are related. So during illness, there's a rise in your stress hormones. These are also called counter-regulatory hormones. These are mainly cortisol and epinephrine, which promote increased circulating glucose by increasing endogenous glucose production and also decreased glucose uptake into the peripheral tissues. So this leads to increased circulating glucose. It also leads to increased free fatty acids through the stimulation of lipolysis. And these two things combined could exacerbate illness by many mechanisms that are listed in the green box on the right side. These include altered tissue metabolism, oxidative stress, hypercoagulability, suppression of the immune system, and decreased wound healing. These complications of hyperglycemia are the reason that hyperglycemia and blood glucose levels in hospitalization matters. So most of our inpatient blood glucose goals are coming from this NICE sugar trial that stands for Normal Glycemia in Intensive Care Evaluation and Survival Using Glucose Algorithm Regulation. It was a large multi-center study of critically ill patients that were randomized to either intensive glycemic management with a goal blood sugar of 80 to 110 milligrams per deciliter, or more moderate glycemic goals of 140 to 180. The study essentially showed no significant treatment advantage in the intensive glycemic management group when it was compared to the group with moderate glycemic goals, but the intensive management group did have a statistically significant, slightly higher mortality rate of 27.5% compared to 25% in the moderate glycemic goals group, with an odds ratio for death with intensive management of 1.14. The intensively treated group also had a 10 to 15 times greater rates of hypoglycemia. So 6.8% of the patients in the intensively managed group had hypoglycemic events versus 0.5% in the moderately managed group. But they didn't confirm that the cause and effect relationship between hypoglycemia and mortality in this study. The NICE sugar trial was also supported by several meta-analyses and another randomized control trial as well. And all of this data together led to the American Diabetes Association blood glucose goal recommendations that I've gone through here. So the threshold to initiate insulin therapy in hospitalized patients is blood sugar of 180 in all hospitalized patients. For target blood sugar in critically ill patients, we aim for 140 to 180. For non-critically ill patients in general, 140 to 180 as well, but there are a select group of patients where we can be a little bit more aggressive and try to get them down to 110 to 140. And mostly these are patients who are in the perioperative period to make sure that they have appropriate wound healing and don't develop wound infections, for example. Patients who are terminally ill or have short life expectancy, anyone who is really high risk for hypoglycemia or have had multiple events, or patients with labile glycemic excursions are candidates to have much looser goals of blood sugar management and just keeping them less than 250 to prevent the symptoms of hyperglycemia, essentially. If a patient has a fasting blood sugar while on an insulin regimen in the hospital of less than 100, we have to reassess that insulin regimen. And that's because this is actually a predictor of a hypoglycemic episode within the next 24 hours for that patient. So that's something to pay attention to. And then, of course, if anyone's blood sugar is less than 70 during their hospitalization, we have to find out what happened. What is the root cause? And if it was the insulin dose, we have to modify that. And if it was something that could be corrected with education, we should educate the team. So how do we monitor patients' blood glucose? First, A1C should be measured in all people with diabetes or anyone who has a random blood sugar of 140 or higher if they don't have a prior A1C in our system at least in the last 8 to 12 weeks. This is because both their inpatient treatment and their discharge planning are more effective when we know their pre-admission blood sugar control. We should be checking point of care blood sugars before meals and at bedtime for anyone who's eating in the hospital. Anyone who's not eating or anyone who's on continuous tube feeds should have their blood sugar checked every 4 to 6 hours, depending on what their sliding scale is that's ordered, or even more frequently every 30 minutes to every 2 hours if the patient is on IV insulin therapy. When anyone has a blood sugar result from their point of care test that does not correlate with their clinical status, we should be getting a venous blood draw in order to assess that it was accurate. And this is also important in patients who have asymptomatic hypoglycemia. So if they are hypoglycemic on their point of care test, we should be confirming that with a blood draw. For patients who come in with continuous glucose monitors, it's okay to have them continue it unless it needs to be removed for some sort of imaging study. But otherwise, it's fine to continue it as long as we also order point of care blood glucose with the parameters that I just went over above. This is we're using the point of care still for dosing decisions and for hypoglycemia assessment, but it's really helpful to keep the CGM on the patient, especially if they end up having nocturnal or prolonged hypoglycemia, or they are a type of patient who has hypoglycemic unawareness and are asymptomatic. It also can prevent hypoglycemia because we'll be able to see a trend down, and the patient will be alerted with an alarm if they're going to be low in the next 20 or 30 minutes. So the hypoglycemic events can actually be prevented. So we shouldn't be removing these CGMs when patients come in. So once we've identified people who would benefit from inpatient insulin therapy, it's important to then put them on a regimen that's actually going to improve their glycemic outcomes and reduce their hospital complications. In most cases, we should be discontinuing oral anti-diabetic agents and starting a regimen based on these ADA standard of care recommendations. Continuation of oral or non-insulin injectables like Trulicity, Ozempic, Victoza, those can be done on a case-by-case basis, but should be approved by the endocrinologist. I won't really go over that stuff in much detail because I want to focus more on insulin. So the ADA standard of care in diabetes recommendations say that basal insulin or basal plus bolus correction insulin is the preferred treatment for non-critically ill hospitalized individuals who have poor oral intake and those who are taking nothing by mouth. So if NPO or eating less than half of each meal, they should be just on basal or basal plus bolus. For patients who are not critically ill and who are eating and have adequate nutritional intake, we should be using basal insulin, prandial insulin, and correctional insulin as the preferred treatment for them. Sole use of correction or supplemental insulin without basal is discouraged, but I'll talk a little bit later about when it actually might be appropriate. So I wanted to go over insulin basics as well. I think knowing and understanding the activity profiles of the different types of insulin can help us prevent hypoglycemia and also better manage hyperglycemia in our patients. There are more types of insulin than what's on this graph. So if any of your patients are on something that seems out of the ordinary, please call me for help. So just going over the types of insulin, the purple dotted line on the left, those are the rapid-acting insulin profiles. So Lispro, Aspart, Glulisine, these usually start working about 15 minutes after injection. They peak in about 1 to 2 hours after injection and last about 4 hours. That's the type of insulin that we're giving before meals or for correction and for meals. Regular or short-acting insulin is that pink line. That begins working about 30 minutes after injection. It peaks around 2 to 3 hours, and it lasts about 6 hours. So regular sliding scale every 4 hours is not something that should ever be ordered because you'll have lots of overlap in your insulin in those cases. Intermediate-acting insulin, or NPH, generally reaches the bloodstream about 2 to 4 hours after injection, peaks 4 to 12 hours later, and is effective for about 12 to 18 hours. And then the long-acting insulin, Detamir and Glargine, reach the bloodstream several hours after they're injected, and they tend to be lowering the glucose levels for about 24 hours. So after reviewing the different basics of the different types of insulin, I want to go over the basal bolus regimen that was recommended by ADA. So on the right side of the slide, I put a little graphic that shows the normal insulin profile, physiologic insulin profile in the darker beige color. It shows the peaks and the falls of insulin with meals and the decreased release of insulin in the fasting state. The goal of using basal bolus insulin is to mimic that physiologic insulin profile as best as we can. The basal insulin is represented by that black line at the bottom. Basal insulin is ideally 24-hour peakless level of insulin to suppress the glycogenolysis, so the liver's release of glucose during the fasting state and between meals. There's Detamir, which we are using right now in the hospital, but it's going to be discontinued soon, so we're going to be adding glargine to our formulary instead. They have similar profiles, so should be used about the same. And then there's bolus or prandial or mealtime insulin. These are the ones that are rapid onset that we're using to prevent that postprandial rise in the glucose. And these are aspart, lispro, or glulisine, and the one that we use in the hospital is aspart. And then there's correctional or sliding scale insulin. This type of insulin dosing is intended just to lower hyperglycemic glucose levels. So it's not intended to cover a meal. So even if a patient is NPO and we're checking their blood sugar every 4 or 6 hours and they're hyperglycemic, they can still get their correctional dose or their sliding scale dose of insulin, because the goal is to just bring their hyperglycemia back down to the normal range. We're not covering a meal, so it's okay to give while they're NPO. The dosing selection for sliding scale insulin is based on an estimated amount of how much insulin would be required to bring a patient's blood sugar back down to 150. And different patients will respond differently, so I'll go over later how I pick which one. But low sliding scale dosing is 1 unit of aspart insulin for every 50 milligrams per deciliter that the blood sugar is above 150. Medium uses 2 units for every 50 above 150. And the most intense, the higher sliding scale, the high sliding scale uses 3 units for every 50 above 150. We use rapid acting formulations for these, so the aspart. The use of basal bolus insulin inpatient is based largely on a study called the RABBIT-2 trial, a multi-center randomized controlled trial where insulin-naive patients with type 2 diabetes were randomized to either basal bolus insulin or just sliding scale regular insulin. So figure 1 on the left side, it shows changes in their blood glucose concentrations in the patients treated with glargine plus glulisine, which is the filled in black dots, compared to sliding scale insulin alone, which is the open black dots. And you can see by the 4th day, there's already a statistically significant difference in their blood sugar control. For figure 2, they're representing those patients that were so severely hyperglycemic on sliding scale insulin regimen alone that they switched them over from the sliding scale insulin to the glargine plus glulisine, and immediately they had much improved glycemic control. Overall, the treatment in this study with glargine and glulisine resulted in significantly better control compared with using the sliding scale insulin alone. There were some hypoglycemic episodes. There were 2 patients in each treatment group. Both of them were just treated, or all 4 of them were just treated with oral dextrose, and none of them were associated with any adverse events. So they did a follow-up study in patients with type 2 diabetes who were undergoing general surgery to evaluate the difference in their post-op complications in those patients who received basal bolus versus those who received sliding scale insulin alone. And there was a significant difference in the composite of complications, which include wound infection, pneumonia, respiratory failure, acute renal failure, and bacteremia. And also a significant reduction specifically in wound infection using the basal bolus insulin regimen. But there are certain population of patients where it is possible to use sliding scale insulin alone. Via their electronic health record, there was a recent study that assessed 8,000 patients treated with sliding scale insulin alone among more than 25,000 patients with type 2 diabetes in the hospital. And they found that the most non-intensive care unit patients who had an admission blood sugar less than 180, who were treated with sliding scale insulin alone, were able to achieve their target glycemic control during hospitalization. Patients who came in with blood sugar above 250, only 18% were able to reach their target glycemic control, 180 to 250 on admission, only about half of them were. But anyone with blood sugar below 180 had an 80 to 85% likelihood of achieving target blood sugar control with sliding scale insulin alone. So we can use it for some people who just have mild hyperglycemia and may not be on insulin at home. So now that I went over the concept of the basal bolus regimen, I wanted to also review how we choose dosing and dose adjustments for insulin inpatient. So for insulin naive type 2 diabetics, and that means they've either never been on insulin before or they have a home regimen that they're not adherent to at all. So we're kind of starting from scratch and deciding on their dose from scratch. In general, you can use 0.4 to 0.5 units per kilo per day. I tend to lean toward 0.5 if it's a patient with obesity who might have more insulin resistance, or otherwise 0.4. 50% of that total daily dose that we calculated should be used for the basal. So 0.2 to 0.25 units per kilo per day should be used for basal, and the rest of it should be split up into 3 doses, 1 for each meal. If the patient has ESRD or they're elderly, more than 65 years old, or they're very thin, you can use 0.2 to 0.3 units per kilo per day, and then it would be 0.1 to 0.15 units per kilo per day for their basal, and the rest would be for bolus. And if someone is obese or on high-dose glucocorticoids, anything that's causing increased insulin resistance, consider using even 0.6 units per kilo per day or higher. For those patients who are already on insulin at home, either type 1 or type 2 diabetes, there are definitely many complexities on how much of their insulin to start on admission based on different factors like their adherence, their current A1C. But in general, a safe place to start is 75% of their outpatient dose and then titrate up. For correctional dosing, the sliding scale that you choose should not only depend on what their blood sugar level is, but rather on how insulin sensitive or insulin resistant you think the patient will be. So low sliding scale is meant for patients who are expected to be very sensitive to small amounts of insulin, or those patients who have a high risk of hypoglycemia. These include a new diagnosis of diabetes, type 1 diabetes without insulin resistance. So there are patients with type 1 diabetes who are also resistant to insulin because they've been on it for so long, or because maybe they're overweight or obese. Those without insulin resistance definitely are very sensitive and should have low sliding scale. ESRD patients and patients with cystic fibrosis related diabetes are also tend to be very sensitive to insulin. Most of the time we'll be using medium sliding scale. It's kind of the standard choice for anyone who has average insulin sensitivity. And high sliding scale is for patients who you're expecting to be very resistant, severe hyperglycemia from high dose glucocorticoids, morbidly obese patients, or patients who are already on 80 units or more of insulin at home or in the hospital. For the day-to-day insulin adjustments, I tend to use this as a general rule, but I'm often even more conservative than this rule just to avoid hypoglycemia. It's a 10-20-30 rule. So it applies to increasing your basal doses based on the fasting blood sugar values and increasing prandial doses based on the pre-meal values. If the blood sugar is above 100, I use 140, then increase the dose by 10%. If it's above 200, you increase the dose of the appropriate type of insulin by 20%, and above 300 by 30%. There are some patients who wake up with a blood sugar of 170, but all of their mealtime blood sugar checks are in the 300s, so I wouldn't adjust their basal in the same way that I would adjust their bolus. So you use this rule separately for the separate types of insulin. And then if blood sugar is below 100, decrease the dose by 10 to 20%. And if they're hypoglycemic, by even more, 30 to 40 to 50%. The most important complication that we want to avoid, whether inpatient or outpatient, is hypoglycemia. And the definition of hypoglycemia is defined in different levels. So level 1 is a blood sugar of 54 to 69. Level 2 is a blood sugar of less than 54. That's typically, the reason that number is chosen is because it's typically the threshold for neuroglycopenic symptoms, which are the symptoms that I've bolded in that little chart underneath. And then level 3 is any hypoglycemia, regardless of what the value is that's characterized by either altered mental status or physical functioning so much that the patient needs assistance from someone else to recover. Signs and symptoms of hypoglycemia are many: anxious, nervous, shaky, sweaty, pale or cool or clammy skin, numbness and tingling, urgent hunger, dizziness, tachycardia, headache, blurry vision, nightmares, and then the bolded ones are those neuroglycopenic symptoms: lethargy, slurred speech, confusion, odd behavior, seizures, or loss of consciousness. Predictors of inpatient hypoglycemia are a prior episode of hypoglycemia, or for that patient, or fasting blood sugar less than 100. So we have to pay attention to those two things and always make changes when we see those to prevent a future event. Because hypoglycemia can result in serious adverse events, I wanted to go over each aspect of care that could lead to a hypoglycemic event, and how both nurses and physicians have a role in preventing these. So first is their diet. We have to have really good documentation in I's and O's about tube feeds and about meals eaten. For tube feeds, it's important to know the current hourly rate and changes in hourly rate, because the amount of insulin they require will probably be different based on the amount of nutrition they're getting. And definitely important to note when tube feeds are held and when they're restarted. For PO intake, percent of meals is important. We're going to be starting to use TID-PC aspart, meaning after meals, we'll give the prandial insulin so that we can be sure patients have eaten at least 50% of their meal when they get their mealtime insulin in order to prevent hypoglycemia. For fluids, it's really important to keep the dextrose-containing fluid orders up to date. So including discontinuing the order if you're not using it, even if you're not using it for 12 hours and going to resume using it the next day, discontinue the order so that it's clear in the MAR, and we can make decisions based on the objective things we find in the health record. And then if dextrose-containing fluids are going to be started or discontinued, it's important to communicate with the person who's ordering the insulin in order for them to be able to make appropriate changes, like scale back a little bit on the insulin dose or give a little bit more if they're going to be starting on dextrose fluids. Important again, like the tube feeds, to document start time, discontinuation time, and rate. For AccuChecks, we'd want to check their blood sugar right before administration of correctional and basal doses. I didn't use prandial doses in here because, again, that will be a separate injection after their meal. We should not be using AccuCheck values that are more than 30 minutes old to administer a correctional dose or a basal insulin dose, because blood sugars fluctuate all the time, and that dose may now be too high for them and could lead to hypoglycemia. Each AccuCheck should be documented. It's imperative to document hypoglycemia in the appropriate place so that everybody who's reviewing the chart, who's making changes to insulin orders, is aware of any hypoglycemic event before changes are made. There's a new order for PRN AccuChecks that should help be able to input an extra AccuCheck if necessary, so that it can actually be in the chart. For the people who are ordering insulin, use the adjusting insulin scale discussed. So try not to be too aggressive when someone's hyperglycemic, although sometimes it is needed. And make sure that we're looking at all the orders, all of the fluids that are hanging, tube feeds that are running when we're making decisions and changes. Personally, I avoid high sliding scale most of the time unless patients meet the criteria that I went over. And that's because it can cause really significant fluctuations in blood sugar. Patients have really high blood sugar because they're going through something that's causing them to be insulin resistant, and the high sliding scale may drop them to a hypoglycemic event, which is overcorrected with D50 and skipping insulin for the next meal, and they go back to 300. So it causes lots of fluctuations that can be avoided, and blood sugar may be a little bit higher, but the fluctuations can be avoided with using moderate sliding scale most of the time. Review insulin dosing and orders when there are any changes to steroid doses, fluids, and feeds. So it's really important for the person who's ordering corticosteroids or glucocorticoid to let the insulin ordering provider know about any changes. For nursing, for insulin administration, insulin should be administered within 30 minutes of a scheduled time, unless it's otherwise indicated or ordered specifically by the team. And that's because if you're outside of the window of the 30 minutes, there may be overlap with the next dose, and that may lead to hypoglycemia if the patient has insulin stacking. Ensure that the sliding scale dose ordered and the administered dose match. Sometimes there are custom sliding scales made, so the numbers may be different than the one you're accustomed to, so it's important to always make sure that those match. And then if insulin is held, document the reason that it was held. Did the patient not eat enough of their meal? Are they NPO? Tube feeds held? Did the physician ask you to hold it? Did the patient refuse? All of those things are important to know how to make future changes to the orders. And always call the physician or NP or PA that's ordering the insulin to clarify any questions or any concerns about administration of the insulin dose before holding or giving it. If you have any concerns, just call. For the basal insulin, if patients are NPO, clarify the instructions about holding or reducing the dose. There are some patients that it's okay to give maybe 50% or even 75% of their basal dose. Some patients who it's absolutely necessary to give their basal dose, if they're type 1, for example. So always clarify. For the bolus prandial insulin, we're, like I said, going to start dosing for prandial bolus insulin after meals. So if the patient is NPO or eats less than 50% of their meal, that should be held. If a patient's pre-meal blood sugar is less than 70, that should be held as well. For the correction doses, I talked a little bit already about avoiding the high dose sliding scale. And then rapid acting correction doses or rapid acting prandial doses should not be given less than 4 hours apart. So if you gave someone a correction at noon and you check again at 2 and their blood sugar is still high and you give them that full correction dose again, they're likely to become hypoglycemic rapidly because of insulin stocking. So unless there's an extra order or you confirm it with the ordering physician or NP or PA, it should be given 4 hours apart. The treatment protocol for hypoglycemia should be initiated if somebody has a blood glucose less than 70 on their scheduled AccuCheck, or if blood glucose is less than 70 when the patient is displaying signs and symptoms of hypoglycemia that I discussed before. And the treatment protocol takes into account their mental status, their PO status, and their IV access. So if a patient is conscious and they can take PO, they should be treated with 15 grams of oral glucose gel that they should swallow. If a patient is conscious and NPO, but they have IV access, they should be treated with a D50 push. And if they're conscious and NPO and do not have IV access, they should be treated with IM glucagon 1 milligram. For unconscious patients who have IV access, D50 push, and for those who do not have IV access, glucagon 1 milligram IV. And then always notify the team to let them know that there was a hypoglycemic event so they can make appropriate changes. After the treatment, the blood sugar should be checked again in 15 minutes, and it's important to also document that one. And then if necessary, you can repeat the same treatment protocol again. And per our hospital policy, if the patient is not in the ICU when this happens, call the rapid response team. So that was a lot about hypoglycemia prevention. Hyperglycemia, we can try to make it a little less severe or prevent hyperglycemia as well by doing a few things. So for patients with type 1 diabetes especially, or patients who are prone to DKA, do not hold their basal dose completely, as they can go into DKA with a skipped basal dose. And the ordering provider should be putting in their order specific instructions on giving a partial dose or giving it anyways if they're NPO. But if there are no instructions, always call. Don't hold 100% of a basal dose for patients who are receiving their basal insulin because of medication-induced hyperglycemia, so they're on glucocorticoids, or other hyperglycemia, which is present even when they're NPO. And then as far as boluses, like I mentioned earlier, correctional doses do not need to be held while patients are NPO because they're meant to correct hyperglycemia. So lack of oral intake does not warrant holding a correctional dose. And if you're concerned about giving a correctional dose, you can always call the ordering provider. And then I wanted to just go over a couple of special situations that might warrant some insulin regimens that are not the standard basal bolus correction regimen. So just basic familiarity with these situations is also important to help avoid complications like hypo or hyperglycemia. So first, enteral feedings. So insulin orders for patients with tube feeds should still aim to cover basal, prandial, and correction needs. Their goal blood sugar is 140 to 180 because the patient is continuously postprandial, and that's our postprandial goal anyways. Ideally, the basal insulin should cover hyperglycemia while they're fasting. So even if tube feeds are held, the basal insulin should be at an appropriate dose that wouldn't lead to hypoglycemia and would manage their hyperglycemia while fasting. And then as far as prandial insulin, that can be calculated using 1 unit of insulin for every 10 to 15 grams of carbs in the enteral formula, or base it off the 24 hours of correctional insulin requirements the day before. I usually do the second one just because you may be too aggressive if you try to guess how much insulin they might need for their carbs. But if you have them on basal and see how much correction they needed and use that for their tube feed coverage, that generally works too. It's reasonable per the ADA guidelines to use MPH every 8 or 12 hours, but this is at this time restricted to endocrine. You can also just use rapid acting insulin every 4 to 6 hours to cover the hyperglycemia secondary to tube feeds. And then it's important to note whether the tube feeds are continuous or bolus feeds because the dosing is going to be different. If tube feeds are interrupted and a patient receives their NPH or they receive their long-acting insulin, a dextrose infusion should be started immediately in order to prevent hypoglycemia. And if the patient is significantly still hyperglycemic on the dextrose infusion, it can be discontinued if needed. For parenteral feeding, so TPN or PPN, it's kind of the same thing. Insulin orders should still aim to cover basal, prandial, and correctional needs. The goal blood sugar is 140 to 180. Basal insulin should cover hyperglycemia while the patient is fasting. And then prandial insulin can be calculated with 1 unit of regular human insulin for every 10 grams of dextrose in the parenteral formula, or based off of 24 hours of correctional insulin requirements. The prandial insulin should actually be added directly into the nutrition bag, and that prevents hypoglycemia because if the nutrition is stopped, then the insulin is stopped. And so it'll manage their hyperglycemia due to the TPN or PPN, but reduce the risk of hypoglycemia if it's held or stopped. And then correction insulin should still be given subcutaneously. Patients on glucocorticoid therapy. So glucocorticoid therapy can induce hyperglycemia in 50% to 85% of patients who do or do not have pre-existing diabetes, and that hyperglycemia can lead to increased morbidity and mortality in the hospital if untreated. When treating hyperglycemia secondary to glucocorticoids, it's important to consider the duration of action of the steroid. So intermediate acting steroids are prednisone or IV methylprednisolone, solumedrol. Prednisone peaks in about 4 to 6 hours and acts for about 12 hours, which is similar to NPH. So this little chart here shows what I would do to cover prednisone is give a weight-based dose of NPH at the same time as the prednisone, and that can be given on top of the basal and bolus insulin. So you'll need endocrine on board in order to do it, but it'll be given on top of the basal bolus insulin specifically to cover the hyperglycemia due to the steroid dose. And then for long-acting or like dexamethasone or patients who are on multiple glucocorticoid doses throughout the day, like a Q6 or Q8, the basal and bolus can just be adjusted appropriately. They tend to need a little bit more adjustment in the bolus than the basal, so you can go up on the bolus insulin by 40 to 60% even at times. But as the dose is changed or the type of glucocorticoid is changed, it's important to note because you may need to pretty immediately decrease the doses of the insulin that you're using. So perioperative care, surgical stress and counter-regulatory hormone release around the time of surgery increases hyperglycemia, increases mortality risk, infection risk, and length of stay. So perioperative blood glucose goals ideally are a little bit on the lower end. Earlier I said 110 to 140 or even 100 to 180 works. Within 4 hours of surgery, it's important to get them in that 100 to 180 range in order to decrease those risks. Special attention to basal insulin dosing. So most often, the full dose of basal does not need to be held prior to surgery if a patient was on an appropriate dose, but they probably do need a reduced dose because they're going to be NPO for a prolonged period of time. So if the order says to hold the full dose, hold the full dose, but if the order is unclear, once again, always just call and ask. The main kind of theme of preventing hypoglycemia and mitigating hyperglycemia is just communication amongst all the people doing all the different steps to take care of diabetes for these patients. So that was everything I wanted to go over today. The major take-home points. So acute stressors in hospitalized patients lead to rise in cortisol and epinephrine, which leads to hyperglycemia, increased free fatty acids, and those together lead to complications that can further worsen their current illness. That's why it's important to maintain their blood glucose goals at an optimal range of around 140 to 180 for most hospitalized patients to reduce their hospital complications. Basal bolus insulin regimens are preferred over sliding scale alone in most cases, except for those cases of really mild hyperglycemia. And then patients with prior hypoglycemia, ESRD, and elderly patients who are at increased risk of hypoglycemia should be managed a little bit more conservatively. And patients on high-dose glucocorticoids or who have severe insulin resistance and are at risk of complications may need to be managed a little bit more aggressively. Communication is key, so PO status, feeding changes, changes in dextrose-containing fluids, glucocorticoid dosing, very important, and documentation of this in the appropriate places in the medical record as well. It's imperative to follow AccuChecks and insulin dosing as ordered and always ask for clarifications before any decisions are made to hold or give insulin outside of a specified time frame. And please try to become comfortable with the signs of hypoglycemia, the symptoms of hypoglycemia, and the treatment protocol because we need to respond to that rapidly when it happens. These are my references, and I have plenty of time for questions if people have questions.
Thank you so very much, Dr. Bedrosian. Wonderful, wonderful presentation. So please, you guys, great opportunity to ask any questions we might have. So please, ask some questions. Thanks, guys.
Hi, it's Dr. Saman. Great talk. Thank you. I was just wondering about your thoughts on SGLT2 inhibitors and inpatient, and we should talk more about trying to get those on formulary.
Yeah, I think that if somebody is benefiting from it outpatient, is stable on it, has no prior history of euglycemic DKA, and has no history or future plans for surgery in the next couple of days, it's definitely okay to continue. But I believe the recommendation is to hold 3 or 4 days pre-op, as well as maybe a day or so post-op, in order to prevent euglycemic DKA. So I think it's a good idea to continue if a patient is not imminently going to have surgery.
Thank you.
Yeah, you're welcome.
Any other questions? Okay. And just one thing, as we had mentioned before, we have a policy that is being revisited and being written. And once that policy comes out, we'll get that to everybody on the units. We'll do an in-service on making sure that we are following that guidelines. So just look for that in the very, very near future. But it does correlate to Dr. Bedrosian's presentation here. So I'm just going to say thank you so very much for your time on this. And I'm going to go ahead, if it's okay, I'm going to send a copy of the presentation in the chat. And then also, if you guys want your CEs, go ahead and make sure you send me a message and we'll get those out to you.
Thank you. Thank you so much for having me. I just put my email in the chat, so if anyone has any questions that they think about later, you can always email me.
Great. Thank you so much. Fantastic presentation. All right, you guys have a fantastic day.